Okay, well, it's a stormy, rainy morning. I guess maybe afternoon now where I am. So I thought, what better thing could I be doing right now? And that answer was to come up with a quick Zoom recording for our discussion on blood pressure. So when we look at alterations of blood pressure, okay, wait a minute. Okay, what we're going to be talking about here are alterations in blood pressure. Alterations. So it should be fairly straightforward. We're either going to have conditions where our blood pressure is too high, pressure that we need to be aware of. Now, remember we talked about this. We said that we could describe blood pressure using an equation that involves some of the factors that influence cardiovascular health this way: cardiac output times total peripheral resistance. And we mentioned last week that total peripheral resistance was a function of blood vessel length, blood vessel diameter, and blood viscosity. So when we talk about blood vessel length, we're saying that total peripheral resistance will go up if there's more blood vessel length. So think about obesity, added fat tissue is very vascular, add about a kilogram or so of fat and you add hundreds of kilometers of additional blood vessel length. So that represents an increase in total peripheral resistance. One of the reasons that people who are overweight are more at risk for high blood pressure is because they have much more blood vessel length. Blood vessel diameter becomes an issue if the blood vessel diameters are reduced, like in atherosclerosis, where we reduce the lumen, we reduce the ability of blood to pass through that part of a blood vessel. That's a reduction in blood vessel diameter. That's going to increase total peripheral resistance. If blood is thicker, like a high hematocrit, then it's going to be harder to push through the blood vessels. So we understand that those values will either increase or decrease depending on whether we increase or decrease length, diameter, or viscosity. Cardiac output was a function of heart action, and that had its own equation, which was heart rate times stroke volume. We're going to talk more about that when we talk about the heart after the test next week. So we'll talk about the factors that influence heart function in that respect. Obviously, the sympathetic versus parasympathetic influence heart rate. Sympathetic increases, parasympathetic decreases. Factors that are going to influence stroke volume were factors like preload, contractility, and afterload. We can throw in one more, venous return. And these are often all going to be related. So those values, those four options, can go up or down or be better or worse and influence stroke volume. Remember, stroke volume was the amount of blood that was going to be pushed out of the left ventricle into the aorta with each beat of the heart. So we can measure, if we add in heart rate as a factor, and we say that heart rate is going to be on a per minute basis, heart rate 60 beats per minute or 70 beats per minute, then now we're looking at the cardiac output factor as a volume of blood that's being pumped per minute, because we've added in a time frame with the heart rate being over a minute traditionally. So what happens in hypertension? Fancy terminology for high blood pressure. In North America, it's estimated that probably somewhere in the vicinity of 30% of the population has high blood pressure. Worldwide, so that's North America, and it's a little bit less than that worldwide. So there's a little bit of a difference. We wonder why there's a little bit of a difference. One of those factors is that in North America, but in worldwide generally, it's a little bit of an issue. There's a much higher incidence of a sedentary lifestyle. And there's a higher incidence of obesity. So in sedentary lifestyle, we're talking about factors that, well, we need to consider at least factors that include poor diet choices, poor activity level choices, poor sleep patterns, that acronym that we used before, DESS, diet, exercise, sleep, and stress. That comes into play when we look at the risk factors that are associated with this kind of a problem. So what else do we need to consider? Other risks? We know that very close to the top of the other list is going to be smoking. And we talked a little bit about the role that smoking plays in the formation of atheromas. So we know that at the very least, smoking will influence the diameter of blood vessels eventually. It has other factors that come into play here that interfere with circulatory efficiencies and can result in high blood pressure, including stimulating the sympathetic nervous system. Alcohol abuse. With our dietary factors in particular, what we're concerned about are the more processed foods, which are often associated with trans fats, lots more fructose, and salt. So those are the factors, those are the ingredients that are in particular going to influence blood pressures and have a negative effect on our overall cardiovascular health. And we know that hypertension or high blood pressure is a risk for cardiovascular disease, for kidney disease, for stroke, etc. One of the things that we're going to talk about in just a couple of minutes is a general term for what can happen with chronically high blood pressure, which is end organ failure. So in this example here, we've indicated that the cardiovascular system is involved. The end organ that we would be most concerned about in this respect would be the heart. In the case of the renal system, it would be the kidneys. In case of the stroke, it's the brain. So how do we define high blood pressure? Most of us are generally aware that the gold standard for measuring blood pressure is about 120 diastolic over 80 systolic. And we're all comfortable with the fact that there's going to be some variations in there because we're all happy with homeostasis and the negative feedback mechanisms we would use to maintain homeostasis. So all we're saying when we pick 120 over 80 is that this dashed line that's on either side of the upper and lower limits would represent our 120 over 80. And depending on the research and depending on the evidence-based research that you use as your sources, we can pick numbers that indicate whether or not we're susceptible to high blood pressure or what we would label as pre-hypertensive. But the cynic in all of us should recognize that some of the research is biased towards pharmaceutical options and solutions. In other words, some of the research that's out there is designed to sell a product more than to address healthcare concerns. So, for example, fairly recently, they've come up with some terminology that is describing stage 1 hypertension as a blood pressure of somewhere around 140 over 90. So the concern that I have, and that those of us who are a little bit cynical with respect to some of the research that's out there is this truly an indicator of high blood pressure? The reality is that not very long ago, the upper limit of a normal systolic blood pressure would be at about 140. And it might be down around 100 at the lower limit, and that's considered to be a homeostatic range. Nowadays, a lot of the research, and I'm putting quotation marks on that, will indicate that 140 is high blood pressure and should be treated. So there's controversy in that respect. Is it truly hypertension? Now, if the new yellow dashed line is hovering around 140, in other words, the upper limit might be closer to 160 and down to 120, now we might be talking about some hypertension. So it's a very subjective line that we need to be aware of with respect to when we diagnose, when we establish a diagnosis based on a measurement like blood pressure through your sphygmomanometer. So we need to be aware of that and understand too that hypertension is a chronic condition. So if you have a patient that's just had to climb 3 steps of stairs and is already nervous because they're coming to see the doctor, and you're administering a blood pressure test on them, and you see that it's high, maybe it's sitting around 140 over 90 or 140 over 100, or maybe it's 150 over 100, but they just climbed 3 sets of stairs and they're already nervous. Those are all indicators of an expected high blood pressure. So one measurement isn't an accurate test. So you might measure when they first arrive, you might measure again a half an hour later, and again just before they leave to get a better idea of where their blood pressure may be sitting. So blood pressure fluctuates quite a bit, the systolic especially, that 120 number especially, based on the state of your patient. So the most common type of hypertension that we recognize now is what's referred to as primary hypertension. This is also known as essential hypertension. You could make an argument that it is even better described as being an idiopathic type of blood pressure. About 90% of North American hypertension is of this type. It's found by coincidence or by incidental on an examination. It might be recognized in a 35 or 40 or 45-year-old individual whose baseline blood pressure creeps up gradually. Maybe over 5 to 10 or 15 years, the baseline has gone from a 120 over 80 to a 140 over 90. It's a quiet, asymptomatic type of presentation until it's not anymore. So this, like I say, most common. It's increasing in North America. It's being seen to some degree in children and adolescents, much more than it ever was before, probably due to those first two risk factors that we discussed up at the beginning of this segment, the sedentary lifestyle and the obesity issues. There are some genetic and environmental factors that can play a role. So when we look at factors that are going to play a role, we've got modifiable risk factors. And those are our standard ones. We've mentioned obesity. We've mentioned a sedentary lifestyle. We mentioned when we talked about atherosclerosis, metabolic syndrome. Diabetes. Our dietary factors that we mentioned, especially if we're looking at salt, has to be pretty extreme. Fructose, and especially our trans fats. And then we have our smoking, our lipid and glucose profiles. So on the non-modifiable side, we know that hypertension creeps up with age and may be better considered as a normal age-related presentation. In other words, if blood pressure is moderately increased, it probably shouldn't be treated. It's just a normal part of the aging process. We talked a little bit about how blood vessels start to stiffen with age. They lose some of their elasticity. That's going to affect diameters of blood vessels and will ultimately expect to see an increase in blood pressure. If there's a family history, there's an increased chance. Certain ethnicities are more prone to hypertension. African Americans and the Native Indians are a little bit more prone to high blood pressure, probably because they've had to adapt to, especially in North American diets, so they're more sensitive to the high salt or lipid or fructose intake compared to what their intakes were traditionally. So the exposure to a North American diet or a similar type of diet has been faster than what the adaptation can be for their digestive system and their livers to be able to adapt to. So those all are factors that probably play a role with respect to why there's some ethnic differences as far as that goes. So if it's non-modifiable, there's not very much we can do about that at this stage of the game. For modifiable, these are the ones that we can have some control over, not always easy control, but some control. So part of the treatment plan is going to always be to involve or include addressing these modifiable risk factors. So what is it about high blood pressure that we should care about? So why do we care? Well, I mentioned that a big issue with hypertension is what's referred to as end organ damage or failure. So this essential hypertension, this idiopathic hypertension, is sometimes called the silent killer because the symptoms of high blood pressure are often absent. In other words, our cardiovascular system has been very good at adapting to the slowly increasing blood pressure over time until there's actual organ failure or damage is already present. And the organs that are particularly sensitive to chronically high blood pressure are the liver, or sorry, the kidneys, the brain, and the eyes. So symptoms may not present until they're close to being irreversible. In the brain, it might be a stroke. In the eyes, it might be blindness. And in the kidneys, it could be kidney failure. So our cardiovascular disease is our most direct concern because if it's end organ failure there, as I mentioned earlier, it's a heart that's most likely to be affected. So it can lead to a coronary artery disease, atherosclerosis in the coronary arteries, that may cause a cardiac arrest, a myocardial infarction, or heart failure, just congestive chronic pressure that results in heart failure. We will talk about heart failure. It looks like it might be in the 400 level of patho. Used to be in the 300. But at any rate, heart failure by definition is simply the inability of the heart to meet the demands of oxygen and nutrient delivery to all the cells and tissues in the body. So the heart just gets weaker, and then eventually symptoms present that indicate the heart's no longer doing what it's supposed to do. So basically what we have is we have an increase in pressure that leads to an increase in collagen production. That would be a normal expectation because there's an increase in pressure. We want to meet that increase in pressure. But there's a relative decrease in elastin production. So we're creating an imbalance. We're losing some elasticity. The blood vessel walls are going to get thicker but less elastic. And this may also lead to some inflammation. And we know that if we increase the thickness, or at least if we decrease elasticity and we promote some inflammation, we may increase the environment for atherosclerosis. When we consider that this person is probably sedentary, overweight with a poor lipid profile, we can understand where the atherosclerosis component is going to come from. And this decrease in elasticity, especially if we add in some atherosclerosis, it represents an increased afterload on the heart. So remember, afterload is the force that the heart has to overcome in order to deliver stroke volume into the aorta. So if pressure is increased in the systemic circulation, that's an increase in afterload. That means the heart's going to have to work harder, and so we're going to have to have increased cardiac contractions, and that may lead to failure. This is not something that's going to happen just because we have an episode of high blood pressure. This is under conditions of chronic high blood pressure. Now, if the coronary arteries are involved with atherosclerosis, we're going to have decreased oxygen delivery to the heart. You combine afterload and decreased oxygen delivery, and we're going to be getting ischemia to the heart. Ischemia to the heart leads us to angina. Angina is an increased risk for myocardial infarction. So this is the primary pathway for cardiovascular involvement as a result of high blood pressure. What's going to happen to the heart as a result of high blood pressure? So we can add in coronary artery disease, and by that I mean atherosclerosis, leads us to ischemia, and ischemia might give rise to angina, and angina increases the risk for a myocardial infarction, which is just a fancy way of saying we've had a heart attack. When we talk about the heart, we'll go through the actual steps that are involved with that whole process. Now, with the kidneys, so basically hypertension gives rise to macrovascular and microvascular changes. So with macrovascular, we're talking about large blood vessels, large and medium-sized blood vessels that are being damaged. So with hypertension, increased risk of atherosclerosis, macrovascular blood flow is going to be affected. When we look at microvascular, we're looking at mostly the capillary beds, maybe some arterioles and venule involvement, but we're looking at capillary beds. So the tissues that are most susceptible then to microvascular injury are places where we have a wide distribution of capillaries. So the kidneys and the retina are particularly sensitive to microvascular diseases. So with the kidneys, we're going to end up with renal damage due to microvascular pathology. So our long-term exposure on capillaries is going to affect autoregulation. If you remember when you talked about the kidney, we talked about autoregulation. There was the release of renin in response to low blood flow. There was the release of chemical messengers like nitric oxide and other messengers that would influence blood flow through the glomerular apparatus and thereby try to maintain a regular or at least a reasonably regular glomerular filtration rate. So we lose, what have I got here? Increased hypertension on capillaries of the kidney lead to loss of autoregulation. So that's going to increase the chances that the glomerular mechanism is going to break down. That'll lead to glomerular filtration breakdown. So that means we're going to have a decrease in efficient filtration and a decrease in reabsorption and a decrease in secretions. Those are the big three functions of that glomerular mechanism. We may even see scenarios where the whole mechanism is broken down to the point where the albumin, the colloid proteins, large molecules that normally stay inside the capillaries, are allowed to escape, and that may show up with protein in the urine, which we wouldn't normally expect to see. Now, the same sort of thing happens with respect to the retina. So the blood vessel damage here leads to retinal detachment and or bleeding behind the eye, and that can ultimately lead to blindness. So end-stage damage, end-stage organ damage to the retina is blindness, to the kidneys it's failure, to the heart it's failure. So these are the sorts of things that we're concerned about, and we know that this increased blood pressure affects arteries of all sizes, and it also increases the risk for aneurysms and for strokes. So in the case of an ischemic type of stroke, which is referring to a sudden blockage, that's going to result from an embolism that might break off from atherosclerosis. A hemorrhagic stroke is more likely to occur as a result of hypertension, where the blood vessels in the brain get weaker and they rupture. And so you get a bleed into the brain that results in damage to the neurons. That's a hemorrhagic stroke as opposed to an ischemic stroke, which is a blockage of blood flow, which again we talked about in the previous class. So let's take a look at this picture here. This gives us a little bit of a, I'm going to try to come up with a color that's going to show up. This will show up. So here we're looking at the heart, and we can see that if we have a small coronary network, referred to then as a microvasculature, the changes in that microvascular, the stiffening, the reduction of the ability of those capillaries to respond to hydrostatic pressures and colloid osmotic pressures are going to interfere with exchange at the sites where these microvessels are located. So we can end up with, let's get going here. So we've got down here, we're talking about coronary artery disease resulting in a heart attack. Deposits that lead to plaque formation. Reduced flow through this one as compared to this one. This is a nice normal blood flow, open blood vessel, thicker wall with some streaks and some atheroma formation, creating some turbulence and reduced flow, damage to the lining of the artery. Large coronary arteries or large arteries in other locations in the body where we're going to have abnormal flow as a result of the atherosclerosis. So these are just showing little changes, examples of changes between both the larger vessels and the smaller ones. So what do we do for treatment of these patients? First thing that we consider with treatment, address, remove, at the very least reduce the modifiable risk factors. So lifestyle changes are a big one. Increased physical activity will improve the elasticity of blood vessels. When we talk about physical activity, 5 to 6 days a week, at least 30 minutes a day. Get the heart rate above the resting level consistently for 30 minutes a day. It doesn't even have to be 30 consecutive minutes. It can be 15 minutes twice in a day. We've learned that at one time we used to say it had to be an hour, it had to be 30 minutes, but we also thought it had to be consistent. Now we know better. It doesn't have to be consistent as long as it's a total in a given period of time and that it's regular. So that's, 5-6 times a week. So lifestyle changes for a lot of people, that's enough. You make these kinds of changes, you lose some weight, you improve your dietary intake, and your blood pressure comes down. When that's not effective, then we can go to the pharmacology. Too often we go to pharmacology early on. Too often, we're interested in combinations of pharmacotherapy that don't have a lot of study support. So we combine an ACE inhibitor with a calcium blocker, and then we add in, a diuretic, and all of a sudden we've got this cocktail of medications with no true evidence of what's affecting the patient over the long period of time. So the drug categories are categories that are going to affect um, blood vessel patency, overall retention of fluids, and those sorts of things. So we've got drug categories that include mechanisms that are designed to reduce the workload on the heart. If we reduce the workload on the heart, there'll be less pressure in the blood vessels. There's medications that reduce total blood volume. Those are the diuretics or the ACE inhibitors. So you've got categories that are designed to decrease blood volume, like an ACE inhibitor. You'll talk more about this, so we're not going to talk too much about specifics here. But you will recall that ACE was the enzyme that converted angiotensin 1 to angiotensin 2. Angiotensin 2 is a major vasoconstrictor, which would decrease blood vessel diameters and increase pressure. So we eliminate that pathway, not completely. These medications are not complete, and that's a good thing. But the other thing that's going to happen is that when we get angiotensin 2, that's a major stimulus for aldosterone. We remember aldosterone promotes sodium reabsorption in the kidney, and water will follow. That would increase blood volume. So the ACE inhibitors will reduce blood volume as well as reduce blood vessel vasoconstriction. So they're an effective medication from that perspective. The diuretics fall into this category as well. They're a standard long-term, they're just addressing total blood volume. So essentially what they're going to do is make you eliminate fluids more frequently. Now we also have, there's what are classified as ARBs that fall into this category. These are angiotensin 2 receptor blockers. That's what the ARB, angiotensin 2 receptor blockers. So they're affecting angiotensin 2 and aldosterone, but with a slightly different mechanism. They're blocking the ability of angiotensin 2 to match up with its receptor. If it can't match up with its receptor, it's not going to promote vasoconstriction in a blood vessel, and it's not going to signal the kidney to produce, or at least the adrenal gland to produce aldosterone. So that's where that mechanism comes into play. There are other types of medications that are designed to reduce systemic vascular resistance. So if we're going to reduce vasoconstriction, essentially, is what we're talking about there, that's where we would talk about these alpha 1 and beta blockers. They can be administered to reduce overall blood vessel vasoconstriction. And some of these other medications overlap with these as well. This is where our calcium channel blockers would come into play here too. So they're designed to reduce overall systemic vascular resistance, in other words, vasoconstriction. You have medications that address the heart specifically, like a beta blocker would, but basically these are categories of treatment for high blood pressure. So that what we've been talking about so far is all described as primary hypertension. Secondary hypertension is that smaller category. About 10% of the rest of blood pressure problems, high blood pressure problems, comes from this category, secondary hypertension. So this would be high blood pressure because of an identifiable etiology, something that we understand, like another disease that results in high blood pressure. So, for example, hyperthyroidism. Cushing's disease, which is an increase in aldosterone and cortisol. And you can have what's called primary hyperaldosteronism. So that's essentially a tumor of the cells that make aldosterone. So you get an increase in the production of aldosterone under those conditions. So other diseases can lead to high blood pressure. Kidney disease itself, it can be created from high blood pressure, but it can also lead to high blood pressure. And then other conditions that might increase the possibility of blood pressure are some drug interactions and some foods may lead to a secondary type of hypertension. With drugs, they can both be legal or illegal drugs. Cocaine will increase blood pressure, and its derivatives will. Glucocorticoid treatments are other drugs like our cortisol. Oral contraceptives will increase blood pressure, those sorts of things. Anabolic steroids will increase blood pressure, so you got both the legal and the illegals working on that. And as far as foods go, we've talked a little bit about some of the foods that are potential sources for high blood pressure. Now, there is something called a hypertensive crisis. So this is a sudden increase in blood pressure. And pretty severe increase in blood pressure. Might go up like to 180 over 120 in a short period of time. So that sudden increase in blood pressure may cause undue pressure on the capillary networks of one or more of the organ systems. And again, we're concerned with the big three: the cardiovascular system, the brain, and the kidneys. And it requires immediate treatment to prevent irreversible damage. So this is also called malignant hypertension. So we need to have immediate treatment and respect. So what's this going to look like? It might present as retinal hemorrhage. So you see some bleeding into the eye. Increase in intracranial pressure, which is going to be a headache and may lead to some vomiting. There'll be some proteinuria and some hematuria, in other words, proteins and red blood cells in the urine. Cardiac arrhythmias, difficulty with breathing, maybe some dizziness. Those are all indicators of an emergency. And the cause of this, it's rare, but the cause is going to come from something often sudden as well, like discontinued use of hypertension drugs. So a patient decides they've had enough, they don't want to keep going on with the medication, and they just arbitrarily decide to quit. So it's not being monitored. So they're at risk of this. You can occur through an autonomic Hyperactivity, and specifically we're talking about sympathetic. Stimulants like cocaine, or even in some cases caffeine, can set us up for this. So these are the types of things that may be behind this sudden increase in blood pressure, but it is an emergency, needs to be treated immediately to prevent irreversible damages. So what about the opposite to all of this? The opposite to hypertension is hypotension. Now, if you remember what the whole purpose of the circulatory system is, it's about delivery within a closed system of oxygen and nutrients to cells and the pickup of carbon dioxide and wastes from cells. So if we have high blood pressure in the early going, why it essentially is symptom free in most people is because those needs are being met. Oxygen and nutrients are being met. Delivery is being met in high blood pressure. The concern is what happens to the chronic exposure to that pressure in blood vessels over time. And built into that poor lipid profile, maybe then we increase the risk of atherosclerosis. In hypotension, what we're concerned about is not adequate enough delivery. So if we're not going to be So it's a failure to meet oxygen demand throughout the cells and tissues in the body that are calling for it. So our most common presentation for this is in the elderly, where you've probably seen it, maybe in clinic or just in an older member of the family. They experience a little bit of orthostatic hypotension. And orthostatic refers to the position that a person is in. So a person is lying down, they get up quickly because they've been called or they've been surprised or whatever the case might be. And the baroreceptors in their central nervous system are not as quick as they were when they were younger. So they don't respond to that change in posture as fast as they should. And what happens is the pressure is not met when they go from being horizontal to being vertical. So there's an immediate reduction in delivery to the brain and the upper half of the body, and they get dizzy and they fall. So that's describing orthostatic hypotension or postural hypotension. So decrease in blood pressure on a sudden upright change in posture. So the systolic pressure drops very, very dramatically in the parts of the body that are going to register consciousness, in other words, your brain. And it becomes an emergency at that particular time. So a patient may experience this on an occasional basis because of the circumstances I just described. They get up too fast from a lying down position and they get a little dizzy. Right? Most of us have probably experienced that. So when you just get a little bit dizzy and you recover within seconds, that's perfectly normal. If you don't recover and instead you faint or collapse, that's orthostatic hypotension. That's a diagnosis now of somebody who's got a little bit more of a problem than just just that few seconds of dizziness from getting up too soon. So it's common to occur in briefly in any of us, but more of a concern in the elderly because it may lead to a fall. And we expect then that the signs and symptoms, especially if it's relatively minor, are going to include things like dizziness, maybe a little bit of nausea, maybe even a bit of blurred vision, all indicators that we're just not getting. And you can get this, what's called a body or bodily dissociation. And that's really just saying that you just aren't quite sure where you are. Most of us have experienced this at some time or another. If you've been in a, like, especially say you have a little afternoon snooze, and then somebody comes through the door, or in the olden days, we'd say the phone would ring, and that gets you out of your little afternoon snooze, and for a moment or two, you're not sure where you are. That's what bodily dissociation refers to. So the most common reasons for this, we've kind of talked about a little bit, but it's really referred to as a gravity-induced pooling of blood in the lower extremities. And it's a slow response by baroreceptors, pressure receptors, pressure receptors, in the central nervous system and in the peripheral system to the change in posture. Slow response by the baroreceptors to the change in posture. And that's going to give us decreased blood flow to the brain. And if it's more serious than that, maybe even a decreased blood flow to the heart. So that would not be just your occasional dizziness from getting up too quickly. This is getting a little more significant as far as that goes. If we have decreased blood flow to the heart, we're going to have a decrease in cardiac output. If there's a decrease in cardiac output, then we're not going to have good delivery into the bloodstream. So it becomes a vicious cycle, which is another way of saying it becomes a type of a positive feedback loop. So what else might be part of this etiology? That's sort of the mechanism what we just talked about. So you might be on medications like the diuretics, reduce blood volume. You might be dehydrated. There could be forms of anemia or blood loss that contribute to this low blood pressure scenario. As far as pathologies go, I mean, as underlying disease might be a factor, like a decrease in aldosterone. That's got a guy's name associated with it. We're going to talk about some of these when we get to the endocrine system. Occasionally, people with diabetes mellitus, they usually have high blood pressure issues, but occasionally it can result from others. Anorexia nervosa, subject to low blood pressure. Patients who are quadriplegics. Are a little bit susceptible to this as well. And possibly people that are on the alpha beta blockers, alpha 1 beta blockers, because they're designed, they not only will help with lowering blood pressure, for example, but they also inhibit that baroreceptor reflex. So they're going to have a factor here in possibly causing this type of orthostatic hypotension as a bit of a problem. So treatment is going to be to increase blood pressure. So that might mean to adjust these medications address dehydration, etc., etc., etc. So this is much rarer of a concern. In seniors, where it's a little more likely to occur, increasing physical activity, ensuring good hydration, those sorts of things are going to be the treatments of choice. They're relatively conservative, but they're effective as well. So we've just talked a little bit about concerns about high blood pressure and concerns about low blood pressure, and that's enough of this particular topic. After our next test, we're going to get talking about the heart.